You switch back and it's silence. Or maybe, I don't know, maybe it's not total silence. Maybe it feels like someone has stuffed a wet cotton ball. So imagine this. You wake up on a Tuesday morning.
Right.
You maybe you reach over for your phone to shut off the alarm.
Just a totally normal morning.
Exactly, a totally normal morning. You hold the phone up to your ear to check a voicemail, and there's just nothing. It is completely dead.
Yeah, that is terrifying.
You switch ears, and there's perfect clarity. You switch back, and it's silence. Or maybe, I don't know, maybe it's not total silence. Maybe it feels like someone has stuffed a wet cotton ball deep into your ear canal.
Right. It feels muffled.
Muffled, exactly, like
Yeah.
you're underwater.
It is a really terrifying sensation.
Yeah.
And the natural human instinct in that moment, the thing almost all of us would do, is to just say, well, I must be coming down with something. Or, I slept on it funny, it's just congestion.
Right. You rub it, you yawn, you try the Valsalva maneuver, holding your nose and blowing to try to pop your ears, and nothing happens.
And then for a lot of people, the ringing starts.
Yeah, a high-pitched whine that just won't quit. But here's the twist, and it's really the entire reason we are doing this deep dive today. That instinct to wait,
Yeah.
to give it a day or two to clear up.
Oh, it's the absolute worst thing you can do.
The word.
It really is. Because what feels like a stuffed ear from a cold might actually be a physiological crisis. In the medical world, we actually often call this a stroke of the ear.
A stroke of the ear. I mean, that is a heavy term. It implies immediate, permanent damage.
It's meant to imply urgency.
Yeah.
We're talking about sudden sensorineural hearing loss, or SSNHL. We've combed through a massive stack of research for this deep dive today. We've got guidelines with the American Academy of Otolaryngology, studies from University College London hospitals, protocols from Oman, and the data is incredibly stark.
It's not just about needing a Q-tip.
No, definitely not. It's about a clock ticking in your inner ear.
So our mission today is to arm you, whether you're a patient, a partner, or even a clinician listening in, with the info to bypass that wait-and-see trap. We're going to look at the treatments, the golden window for recovery, and some hidden causes. But first, let's get precise.
Yeah, definitions are key here.
How do we actually define this? Is it just my ear feels weird?
We need to be very specific because blocked ear is just a vague symptom. The medical guidelines give us a pretty clear rule of thumb called the 30-33 rule.
The 30-33 rule. Okay, let's unpack that. What is the first 30?
The first 30 is decibels, a sudden loss of at least 30 decibels.
Which means what, practically?
Wait, to give you context, a normal conversation happens at about 60 decibels. A whisper is about 30. So if you suddenly can't hear a whisper, or if normal speech sounds really muffled and distant, you've hit that threshold.
Okay, so a significant drop in volume. What about the second 30?
That refers to frequencies. The loss has to affect at least 3 consecutive frequencies on a hearing test.
So it's not just high pitches or low pitches.
Right. This is important because it distinguishes SSNHL from just losing a tiny slice of hearing due to noise exposure or, just age. This is a broad knockout of the hearing range.
And the final 3?
The time frame.
Yeah.
This all happens within a 3-day window, so 72 hours.
Wow, that's fast.
Sometimes it's instant, like a pop and then silence. Sometimes it deteriorates rapidly over a couple of days. But if you hit those 3 criteria, 30 decibels, 3 frequencies, within 3 days, you are in a medical emergency.
And this brings us to the most critical part of the research, which is the timeline. I was reading through the study from University College London hospitals, the UCLH data, and the statistic that jumped out at me was just staggering. It's about this golden window for treatment.
Yeah, this is arguably the most important takeaway from the UCLH data. They analyzed hundreds of patients and found that those who received steroid treatment within 7 days of onset were 5 times more likely to fully recover their hearing compared to those who didn't.
5 times. That is a massive difference.
It's huge.
I mean, that's the difference between hearing your kids laugh and needing a hearing aid for the rest of your life.
Exactly. But here is the tragedy found in that exact same data. Only about 60% of patients actually get treated within that window.
Why? I mean, if the difference is that stark, why are so many people missing the boat? Is it the patients waiting at home? Or the doctor's missing it?
Honestly, it's both, but the misdiagnosis trap is probably the biggest hurdle. There's a story in the source material about a woman named Caroline that really illustrates the problem perfectly.
Right, Caroline. I remember this. She woke up with a blocked ear and vertigo.
Yeah, dizziness.
And she did the right thing. She contacted her doctor immediately, but the doctor basically said it's earwax, or maybe fluid from a cold.
And that is the classic trap, because 90 to 95% of the time, a blocked ear is wax or fluid. It's incredibly common. So primary care providers, if they aren't specifically tuned into SSNHL, will just prescribe drops or antibiotics and say, come back in 2 weeks.
And for Caroline, those 2 weeks were the whole ballgame.
They were. By the time she realized it wasn't wax, the window was closed. She has permanent hearing loss now.
God, that is so frustrating.
It happens far too often. And for the clinicians listening, or even patients advocating for themselves, there is a very simple tool mentioned in the guidelines that can completely prevent this.
What is it?
You don't need a $1 million machine. You just need a tuning fork.
Like the old school metal fork.
The old school metal fork.
Yeah.
Specifically doing the Weber test. It helps you distinguish between conductive hearing loss, which is the wax or fluid blocking sound from getting in, and sensorineural loss, which is actual nerve damage.
Can you explain how that works? Because reading about it, it seemed kind of counterintuitive.
Sure. You strike the fork and place it right on the center of the forehead. If the problem is conductive, like a physical plug of wax, the sound will actually seem louder in the bad ear.
Louder in the bad ear? Why would a blocked ear hear it louder?
It's called the occlusion effect. Because the ear is blocked from outside ambient noise, the bone vibration from the fork resonates more loudly inside that closed chamber.
Oh, okay.
Think of it like plugging your ears with your fingers and humming. It sounds really loud inside your head.
That makes total sense. Okay, so if I have wax, the fork sounds loud in the blocked ear. What if it's SSNHL?
If it's sensorineural, meaning the nerve is actively dying, the sound will be quieter or completely non-existent in the bad ear. It will lateralize to the good ear because that's the only nerve actually picking up the signal.
Okay, so the clinical pearl here is if the ear canal looks clear, the eardrum looks normal, but they cannot hear the tuning fork in that bad ear, what do you do?
Then you must assume it is SSNHL until proven otherwise. If the ear looks completely normal but doesn't work, that is a massive red alert. You treat it as an emergency immediately.
Okay, so let's say we catch it, we bypass the urgent care, we get to an ENT within that 7-day window. What are we actually doing? What's the first line of defense?
We bring in the heavy artillery, systemic steroids, usually a high-dose oral prednisone.
And when you say high dose, we aren't talking about a little anti-allergy sniffle dose.
No, definitely not. The protocols, like the ones from Johns Hopkins and the Omen Ministry of Health, they suggest something like 60 milligrams a day, or roughly 1 milligram per kilogram of body weight. You take that for about 2 weeks and then slowly taper off.
What is the actual goal there? What are we trying to do to the inner ear with all those steroids?
We are essentially trying to put out a fire. The leading theory is that there's massive inflammation in the cochlea, which is the spiral part of the inner ear.
Right.
That inflammation is causing swelling that cuts off blood flow and oxygen to the tiny hair cells that are responsible for hearing.
And these hair cells are pretty sensitive, right?
They are incredibly fragile, and crucially, in mammals, they do not regenerate.
Once they're gone, they're gone.
Exactly. Once a hair cell dies, it is gone forever. So the steroids are there to aggressively reduce that swelling and rescue those cells before they cross the point of no return.
But taking high-dose steroids for weeks, that is a rough ride for the body, isn't it?
It is. We have to be really honest about the side effects here. Patients might experience high blood sugar, elevated blood pressure, difficulty sleeping. Insomnia is very common, mood swings, severe anxiety.
Yeah, roid rage and sleepless nights.
Basically. But, and this is the vital conversation the doctor has to have with the patient, you are weighing 2 weeks of feeling jittery and not sleeping well against the rest of your entire life with hearing loss in that ear.
Yeah, that puts it in perspective.
Most patients, and really most experts, agree that the chance to save the hearing is worth the temporary systemic cost.
Right, it's a salvage mission. Now, speaking of side effects, the sources mention another way to get the drugs in, something that sounds a little more precise, but maybe a lot more painful. Intratympanic steroids.
Yes, this is becoming much more common. Instead of swallowing a pill that goes through your whole bloodstream, the ENT numbs your eardrum and passes a long, thin needle directly through it to inject a steroid solution, usually dexamethasone, right into the middle ear.
A needle through the eardrum. I am wincing just saying it out loud.
I know it sounds worse than it is. It's done right in the office, usually with just local anesthesia.
And what's the benefit of doing it that way?
The advantage is simple. You get a very high concentration of the drug right where it's needed, the inner ear, with almost zero systemic side effects. No sugar spikes, no insomnia, no mood swings.
So why don't we just do that for everyone from the start? Why bother with the oral pills at all?
But it is still invasive. There's a small risk of leaving a hole in the eardrum, a perforation. It can cause temporary dizziness or pain. But the research, specifically the CODIT study we reviewed, shows it's incredibly valuable, especially as salvage therapy.
Salvage therapy, meaning the pills didn't work.
Exactly. If a patient takes the oral steroids for 2 weeks and sees no improvement, we don't just give up. We can switch to these injections.
But the clock is still ticking.
It is. The data showed that patients who started these injections earlier, around day 13 or 14, had much better outcomes than those who waited until day 20 or later.
It really does all come back to speed.
Speed is the only variable we can really control here. In fact, some aggressive protocols now suggest combination therapy. Don't even choose. Do both.
Oh, wow. Take the pills and get the shot.
Take the pills and get the shot simultaneously to just maximize the absolute chance of recovery.
Throw the kitchen sink at it.
Exactly.
Now, there is another treatment mentioned in the sources, but it seems a bit more controversial. Hyperbaric oxygen therapy. Putting the patient in a pressurized tank.
Yeah, this is the adjunct therapy. It's rarely a standalone cure. The idea is that by increasing the atmospheric pressure, we can force more oxygen into the blood plasma and subsequently into the fluids of the inner ear, helping those struggling hair cells survive.
Does actually work.
That is the big debate. The Cochrane Review and the CMAJ sources are pretty cautious about it. They say it might provide a marginal benefit, but the quality of the evidence isn't amazing. And practically speaking, it's difficult.
How so? Just finding a place that has one.
You need a specialized facility that has a hyperbaric chamber. It's expensive. It takes a lot of time. We're talking multiple sessions, usually 90 minutes each, every single day for weeks.
Oh, wow.
And you have to start it immediately. If you are 4 weeks out from the hearing loss, the guidelines basically say don't even bother. It's strictly for that acute phase. So if you have access and resources, it's an option to add on, but it should never delay the steroids.
Okay, so we have treated the inflammation. We have pumped the ear full of steroids, maybe even sat in a pressurized tank. But we need to talk about the scary red herring in the room. Because looking at the diagnostic section, I see brain tumor listed.
Yes, we have to address this. It's the 3% rule. In about 3 to 4% of SSNHL cases, the cause isn't just random inflammation or a virus. It's a growth called a vestibular schwannoma, or an acoustic neuroma.
Which is a tumor on the hearing nerve.
Correct. It's benign, but it causes hearing loss as it grows slowly and compresses the nerve. And here is the aha moment that trips up even very experienced doctors. You can have a tumor, take steroids, and your hearing can completely recover.
Wait, really? The tumor didn't go away, but the hearing came back?
Yes. The steroids reduce the swelling around the tumor, allowing the nerve to conduct the signal again. So the patient thinks, I'm cured. It was just a virus. But the tumor is still there, slowly growing.
That is a wildly dangerous trap. So a full recovery of hearing is not a clean bill of health.
Never. That is why the guidelines are absolute on this. Every single patient with sudden sensorineural hearing loss needs an MRI of the internal auditory canal with gadolinium contrast.
A mandatory MRI, even if I can hear perfectly again.
Even if you are hearing a pin drop in the other room, you cannot skip the MRI.
What about other tests? Because I saw something in the notes called ABR, auditory brainstem response. Can't we just do that? I imagine it's cheaper.
It is cheaper, but it's not sensitive enough. The sources point out that ABR can miss anywhere from 8 to 42% of small tumors.
42%.
Yeah. If you are trying to entirely rule out a tumor, a test that misses up to 40% of them is statistically useless. You need the MRI.
And the MRI might catch other things too, right?
It might. It's rare, but sometimes SSNHL is the very first sign of multiple sclerosis or a small stroke or a bleed in the inner ear. The MRI sees all of that.
Let's talk about the future for a second. If I'm the patient, I'm sitting in the doctor's office, I've had my steroids, will I hear again? What are the actual odds?
It's the hardest question to answer because everyone is so different. But generally speaking, about 1/3 recover completely, 1/3 recover partially, and 1/3 see no improvement at all.
Okay.
However, we do have prognostic factors, clues that tell us how likely recovery is.
What are the bad signs?
Age is a big one. If you are over 60 or 65, depending on the study, the recovery rates drop significantly. The severity matters too. If you are completely deaf, profound hearing loss versus just a moderate loss, it's a lot harder to bounce back. And vertigo.
If the room was spinning when the hearing went out.
Yes. If you had vertigo at the onset, it suggests the damage isn't just to the cochlea, the hearing part, but has extended to the vestibular system, the balance part. That implies a much larger area of damage, which is a negative predictor.
Makes sense.
And of course, the delay. If you waited more than 10 days to start treatment, the stats just look worse.
We also need to mention the constant companion of hearing loss, which is tinnitus.
Yes. Almost everyone with SSNHL has ringing. It can be incredibly distressing. For many patients, the ringing is actually worse than the silence.
Does it ever go away?
The good news is, as hearing recovers, the tinnitus often fades.
Yeah.
But even if hearing doesn't fully return, the human brain is remarkably plastic. It habituates.
It gets used to it.
It gets used to the sound over time, filtering it out like background noise from a refrigerator. But initially, it requires a lot of reassurance and counseling because it can cause severe anxiety.
So bringing this all together, we have covered a lot of medical ground today. What does this mean for the person listening right now?
It means we need a pretty major culture shift. We've trained ourselves to think of ear problems as minor annoyances. Wax, water, a cold. We need to completely reclassify a sudden drop in hearing. We need to treat it with the exact same respect we treat vision.
Yeah, if you woke up and couldn't see out of one eye, you'd be in the emergency room in 10 minutes.
Exactly. You wouldn't say, oh, maybe I just have eye wax. You'd go, we need that same urgency for our ears.
So the call to action is clear. If you or your partner or your parent wakes up and says, my ear is blocked, and they can't clear it immediately,
You don't go back to bed. Do not wait for it to pop. Go to urgent care, go to the ER, or call an ENT and say, I have sudden hearing loss. Use those specific words. Demand a hearing test, not just a quick look in the ear with a light.
and if the doctor says it looks fine, try these drops.
Be annoying. Ask for a tuning fork test, or ask for an audiogram referral immediately. Better to be safe and wrong than to wait 7 days and lose your hearing forever.
Speed is the weapon.
Speed is everything.
You know, what I find really humbling about this deep dive is the ultimate mystery of it all. We have these intense protocols, heavy steroids, injections through the eardrum, hyperbaric chambers, MRIs. We throw absolutely everything at it. But the source material admits that in 90% of cases, even after all that, the final diagnosis is idiopathic.
Which is just fancy doctor speak for we don't know the cause.
Exactly. It could be a virus, a blood clot, some autoimmune reaction. We rarely ever find the smoking gun. We just see the damage left behind.
It is humbling. The inner ear is a microscopic, fluid-filled fortress encased in the absolute hardest bone in the human body. It's incredibly hard to study and hard to access. We are treating the aftermath without always knowing the enemy.
Which makes that 7-day window even more critical. When you're fighting an unknown enemy, you just can't afford to give it a head start.
That is the perfect way to sum it up.
Well, thank you for walking us through this. It's one of those topics that you really hope you never need to know, but if you do, this information changes everything.
My pleasure. Stay listening out there.
And that's it for this deep dive. Take care of your ears, and we'll see you next time.